Hello, everyone. Professor Canali here. We are going to go over Module 3, which is Respiratory. This is your final module for Exam 1. So you can see you do have a lot of readings for this module, but I'm just looking in your Canvas shell as I go over this. And what your objectives are is they really want you to go back and remember some of your basic concepts of oxygenation. But we are going to be reviewing respiratory function. You need to review the basic airway management. And then we're going to get into more invasive new concepts like ventilator management and ventilator weaning, which we will actually do in class. But we're going to talk about pulmonary embolisms, acute respiratory failure, acute respiratory distress syndrome, chest trauma, and you also have review on your blood gas interpretation and interventions, and review on your chest tube and drainage management. So what they want you to be reading this module is the new chapter is chapter 27 in your MedSurg textbook, but then they have all of these other chapters that are listed for review. And then all of these ATI readings are also recommended for review as well. So we're going to start with your new concepts from chapter 27. Our first concept is pulmonary embolisms. This is any sort of obstruction of one or more of the pulmonary arteries. So it's coming from a matter that's coming from somewhere inside the body. So it's typically caused by a thrombus, but it also could be caused by a piece of a tumor, that fat, amniotic fluid. And if it was from that, that would be referred to as a non-thrombotic pulmonary embolism. And those are incredibly dangerous. So there are, by far, though, the most common cause is due to the DVTs. Basically, what happens is that clot is going to break loose from the site of origin, most often from the leg or the pelvis, and then it travels up to the pulmonary arteries. You also can remember, here we have Virtue's triad. So it has the three predisposing factors that are listed here: the hypercoagulability, venous stasis, and the intimal damage of the vessels. That is known as Virtue's triad, which is definitely a risk factor, but the most common cause of a DVT is that prolonged immobility. So those are the types of clients that we would be thinking about that are at risk for having a DVT. But also obesity, smoking, again, any fracture, bone fracture, especially of the hip or the leg. If they're over the age of 50 years old, maybe they're on estrogen. If they're pregnant, those are all other risk factors. Spinal cord traumas because they're immobile. PE in the past was pretty complicated. Still prior to 2020, the incidence of PEs was approximately 1 to 2 per 1,000 people, and up to 100,000 patients would die from a pulmonary embolism. So it also was a very common complication of SARS and COVID virus, and a lot of those patients did end up developing PEs, which is pretty sad. What ends up happening is this term called VQ mismatch. And we do have a video linked here, and I do recommend watching this because this can be a confusing concept for students. But basically, you just have to think about what is causing the pulmonary embolism to begin with is that this object, this blood clot or some sort of matter is now in the lungs. So it's lodged into that pulmonary artery and it's blocking that blood flow. So if that happens, then we're not getting oxygenation in an equal balance. So that obstruction is going to result in an impaired ventilation to perfusion ratio. That's what this VQ mismatch is referred to. And it's basically just a decreased blood flow to the functioning alveoli or areas of the lung where gas exchange can take place. So a pulmonary embolism is going to result in what's called a high ventilation, low perfusion scenario, which is a high VQ mismatch. This really prevents that gas exchange to happen. So that's going to lead to hypoxemia, which is that low blood oxygen level. If that happens, we're also going to see an increase in that pulmonary resistance because that blood flow cannot travel appropriately. So it can't get past that obstruction. So if that can't get moving, then we're going to see some problems with our preload. It's going to be reduced. So that again, if we're not getting blood flow, that's going to cause further reduction in oxygenation, decreased cardiac output, and hypotension. So that combination is not good. And now we're getting that inadequate tissue perfusion at the cellular level. So now we're hypoxic. So you're going to see a lot of sudden signs and symptoms here. Basically, they're going to have really sudden onset symptoms. So that's when you would really have a red flag in your mind that this is a pulmonary embolism, is if all of a sudden they're really dyspneic, they're having really severe chest pain, and they're breathing really fast. That's usually the first indication that they have an acute PE. So you would suspect that in any postoperative patient that you're dealing with. So any type of sudden shortness of breath in their post-op, you would immediately be concerned. So if it's a massive PE, like meaning it's very large, they could also have jugular venous distension, JVD. They could also become tachycardic just because of that decreased cardiac output. So they could have a low blood pressure as well. So what you want to do is get this diagnosed right away. So they're going to have multiple different tests done. It's done through imaging as well as labs. So if anytime our patient's complaining of chest pain, we obviously always have to do an EKG immediately because we want to make sure they're not having a MI. So if the PE is very large, there could be changes on the EKG as well. But you're going to do a chest x-ray because that can be done fast. And we're just making sure there's no other respiratory problems going on. But what you're really going to do is this spiral CT. That is the most common test to diagnose a PE. It's very effective. It can really identify a peripheral embolus as well. So they are going to do intravenous contrast with the spiral CT. That's what that is. So that's the most common, but the pulmonary angiograph is the most definitive because that's actually visualizing the pulmonary vasculature. So remember, they're going in and they're seeing it so they can actually view that obstruction that's going on. But that's more invasive and it takes more time. So especially if the patient is unstable. So if we don't have to do that, we're not going to. If you can see it with a spiral CT scan, maybe they don't end up having a pulmonary angiograph. But once the patient has been stabilized, you're going to end up doing a Doppler of the legs to look for more DVTs because recurrent pulmonary embolisms is a major cause of mortality. So we want to make sure that there's no further clots going on. Blood work wise, you're going to definitely do a plasma D-dimer. It's very specific to identify the presence of any sort of thrombus in the body. So a D-dimer is like a fibrin from all that lysis, that breakdown that's going on. So you could see that. So a negative D-dimer rules out the possibility of a clot. So a positive one, though, is going to show that there is the presence of a clot and needs further testing. So that is the first blood test done when you suspect a pulmonary embolism at all. Anytime our patients are in any sort of respiratory distress, you're always going to think about ABGs. So we definitely would do an ABG. So at that arterial level, you're going to see that PaO2 most likely is going to be less than 80, which shows that that patient is experiencing hypoxemia. And you're also going to see them in respiratory alkalosis. So that CO2 will be less than 35 due to the patient's increased respiratory rate. So the ABGs later, though, they could change depending on the stage of that, could reveal eventually metabolic acidosis because that hypoxemia has been ongoing, and now that body, we're trying to compensate, we're switching to anaerobic metabolism in the later stages of PEs. So again, and because this that could have some cardiac manifestations, that would be the reason why you would be evaluating a BNP as well. Because remember, when we have any sort of strain on the ventricles, that the B-type natriuretic peptide could be elevated. That's showing that those ventricles are being overstretched. So remember, if that is another indicator for heart failure, if those levels are above 100. So it is an insensitive test for PEs because not all patients with an acute PE have heart failure. So yeah, that's just another diagnostic to help rule out things. So how do we want to treat this? Well, if they're symptomatic, it might be a little bit different than if they're asymptomatic. So if they're symptomatic, we need to support the symptoms that the patient is having. We want to ensure that they're getting oxygenated. And then we want the curative care. We need to remove or reduce the clot because we don't want further clot problems. We don't want that clot to get bigger. So the provider is really going to choose the treatment based on how the patient looks, their risk factors, and if they have multiple comorbidities. So the medication therapy when treating an acute PE is typically anticoagulants. So that is not going to reduce the size of the clot. It's going to keep the clot from getting larger, though, and it's going to reduce the formation of other clots. If they're asymptomatic and they have like a low risk, anticoagulation usually is just going to consist of oral factor XA inhibitors that inhibit that conversion of prothrombin to thrombin. So these patients don't require hospitalization, but on the other hand, if they are symptomatic with PEs, they are hospitalized and we need to treat that with IV heparin. So heparin is initiated for any type of symptomatic pulmonary embolus. If it's a blood clot, if it's air, if it's fat, because eventually those platelets are going to aggregate and the blood clots are going to adhere to those. So it's going to make that obstruction larger, which we don't want. So typically our patients are started on an IV heparin and they're getting bolused. So they're bolused first, depending on their weight, and then they have a continuous drip going. So heparin therapy is really monitored carefully. So you have to look at that activated partial thromboplastin time, the APTT time. So prior to starting the infusion, you have to draw a APTT level, and then you repeat it every 4 to 6 hours to monitor the therapy. So it's very continuously done. And this is done on a general med-surg unit. Your facility is going to have a policy, and it's going to tell you how to titrate the heparin drip based off of your lab values. So that is something that you typically don't call the provider for after the initial bolus and initial dose. You normally just follow the policy for titration. So what you are doing though is once you get to a therapeutic goal, it's typically 1.5 to 2.5 times the normal value, which is 40 to 90 seconds. So that's then if you get them to goal, you might just be keeping them at that same infusion rate, but you might have to titrate that dose up until you get them therapeutic. If it continues to stay low, they might give an additional bolus depending. And again, they're going to titrate the drip. So once it's therapeutic for 2 consecutive lab draws, then you can actually change that evaluation. It's not as frequent. You might just be drawing blood every 12 or 24 hours, depending on where you are. So again, every facility is going to have something going there. But you do really want to make sure that you're monitoring them carefully for adverse outcomes. So if they were starting to bleed, you need to know the protamine sulfate is the reversal agent for heparin, and that should always be readily available if active bleeding occurs. Once they're stable, these patients are actually maintained on anticoagulation for at least 3 months, typically after they're discharged. So then they would be going home though with like low molecular weight heparin. So maybe like warfarin, like the other name is Coumadin. Therapy is monitored, and that is monitored with the INR. So we would want their INR to get to 2 to 3, and it usually does take 3 to 5 days to reach that therapeutic level. So initially, they're prescribed heparin and warfarin concurrently so that we can get them more therapeutic. If they are severely compromised, like hemodynamically compromised, that is when they might go to thrombolytic therapy, which is your ACEs. So that's your alteplase would be an example of that. And that is different because that actually removes, like that's breaking down the clot. So obviously there's a lot more risk with that. So the adverse effects may preclude their use. We might not want to use those. So the risk of bleeding is paramount. We really want to monitor them for bleeding. So especially if they're older, they just are really at risk for that cerebral hemorrhage. So patients typically have IV heparin administration discontinued if they're getting alteplase infused. And then it would be restarted after that infusion is completed. But you really have to make sure all contraindications are considered before you initiate that type of therapy. So we also would probably have them on isotonic fluids just to kind of decrease that thickness of the blood. So it would depend. But there is a really good chart in your textbook. Chart 27.4 goes over all the medications that are used in the treatment of PEs. And they also have the reversals listed, and they have what you should be monitoring for there. So look at that, and then look at table 27.5, which goes over your contraindications to thrombolytic therapy. So remember, if they have any history of hemorrhagic strokes, they cannot get thrombolytics. If they had recent surgery, recent trauma, which the time frames typically less than or equal to 2 months, or if there's any active or recent internal bleeding within 6 months, then they cannot have thrombolytic therapy done. We would only be doing surgery if it's really, really massive. And typically it's just an embolectomy. They are just going to physically remove the clot. They could also put in a filter to prevent those clots from being able to travel up again into the pulmonary artery. So they prevent recurrent PEs from happening. But if there's like any sort of active bleeding, like if they aren't able to do the anticoagulation therapy, that's when they would be more likely to place one of these filters in. It still allows like blood passage, but it really traps that embolus, as you can see here in the picture. So they are kind of nice, and the complications honestly are pretty rare. But maybe the filter moves. That would probably be one of the most common complications of that, the migration. Yeah, they're nice. So you might see those as well. So what do you need to do? You have to really, again, you want to identify it as fast as possible. So if they're suddenly, again, short of breath or having that chest pain, you want to definitely think that, does this patient have a pulmonary embolism? So think back to your ABC. So we really want to monitor the airway, their oxygenation. We're going to do frequent vital signs. We're going to anticipate drawing labs. Again, remember that tachypnea, we would anticipate respiratory alkalosis, that PaO2 is going to be reduced because that PQ mismatch that's going on. And if that continues to progress, their ABGs would change to metabolic acidosis because of that hypoxia that has developed into anaerobic metabolism. So the coags you need to draw. So you're going to have your APTT levels are monitored if they're on a heparin drip, and you're going to do a PT-INR if the patient is on warfarin. You definitely, again, always want to monitor their urine output. because if it's less than 0.5 mLs per kilo per hour, that could be a sign that they're progressing into shock. So you always want to elevate the head of the bed right away because it's going to help them breathe better. You want to decrease that viscosity of the blood, which is why we would give IV fluids. We're going to administer our anticoagulation medications as ordered. So anticipate doing the heparin infusion if they're symptomatic, and administer the thrombolytics if necessary, if it's ordered. So again, those thrombolytics are what degrade the clot. So if it's not contraindicated, they're used if the patients are hemodynamically compromised. You might have to help the heart, so you might have to give them some other medications too, like inotropes, or like something like norepinephrine or vasopressin, just to keep that systolic blood pressure of at least 80. Always monitor them for bleeding, put them on bleeding precautions. So minimize venipunctures. You're monitoring their urine for any sort of blood, their stool for any sort of blood, even sputum, bruising, always watch for that. And if it is a really large PE, they could go into cardiogenic shock. So you would be prepared for intubation and resuscitation if necessary. What you want to educate the patient on is any of the risks of having a pulmonary embolism to avoid this from happening again. You want them to exercise, a cardiac healthy diet, that they're drinking adequate fluids, they're not smoking, that they're taking their medications as prescribed, especially if they're being discharged on anticoagulants like warfarin, that they need to be aware that they have to go get their blood drawn, that is necessary. It is required with the warfarin, right? And honestly, you would want to make sure they understand bleeding precautions, that they can't go home and use an electric razor at this time, that they shouldn't be flossing their gums because all of that could cause bleeding. And we wouldn't want them to go do heavy sports and get that because of that risk of bleeding. So you're educating them on any signs and symptoms of bleeding. Bruising, right? And again, the diet, if they are on that, we want to limit food high in vitamin K because of the warfarin. That wouldn't make it as effective. So making sure you can tell them what foods are high in vitamin K. So that is pulmonary embolisms. So please, if you have any questions on that, write it down, because now we're going to get into acute respiratory failure. And we're going to get into acute respiratory distress syndrome. So acute respiratory failure is kind of a blanket statement. We're saying that one or both of these gas exchange functions in the lungs are not working the way that they're supposed to be working. So we're not getting adequate oxygenation and ventilation, and we're not removing that carbon dioxide the way that we want to. So we're seeing hypoxemia, we're seeing hypercapnia, that high elevation of CO2. So there's two different types. There is hypoxemic respiratory failure and there's hypercapnic respiratory failure. So this kind of demonstrates that your type 1, that hypoxemic respiratory failure, is when we have that PaO2 less than 60. So, and this is happening despite increased inspired oxygen. So I'm giving them oxygen and it's still impaired, but they also have a normal or a low CO2. So on the opposite end, that hypercapnic respiratory failure is they're demonstrating respiratory acidosis, that CO2 is greater than 50 and the pH is less than 7.35. On the other hand, hypoxemia may or may not be present in these cases. So they are two different things and they're caused by two different things. So the prevalence of acute respiratory failure really varies. It's, however, life-threatening because we're talking airway, we're talking breathing here. So it does really have a high mortality rate. So it's those risk factors for the hypoxemic respiratory failure are really going to be any sort of disease that produces that VQ mismatch, or that impairs oxygen diffusion, So that could be things like pulmonary edema, pneumonia, think back to pulmonary embolisms. But on the other hand, if we're thinking this type 2 hypercapnic, we're thinking the opposite end. You're thinking like disease that's impairing ventilation and it's causing hypoventilation. So it's usually seen in any patient that has impaired chest wall movement. So that could be something like a narcotic overdose or like myasthenia gravis because they just have that impaired chest wall movement and a flare up. So it could also be due to a trauma. So the patient could be seen, they have a chest wall injury or trauma. And those patients also typically will be hypoxemic if the cause is not quickly reversed. So there is a really good chart in your textbook, 27.6, that goes over the risk factors for acute respiratory failure. So again, the impaired ventilation, which is hypoventilation, would be things like my airway obstructions, anesthesia, because it's slowing it down, and opioid administration, my pain medication. But on the other end, impaired diffusion, like at my alveolar level, would be due to something like pulmonary edema or acute respiratory distress syndrome, which this could progress into. A ventilation perfusion mismatch could be something related to a restrictive lung disease like pulmonary fibrosis because of that thickness in the lungs, pneumothorax, atelectasis, right? Those lungs kind of collapse. Those could all be indicators of that as well. So again, what are you going to see here? Well, you're going to see different signs and symptoms depending on what they have, which I'm actually just going to go back to the prior slide because underneath here we have the signs and symptoms listed. So you can see that if they're hypercapnic, so that CO2 is high, then that's when you see symptoms like the headache, confusion, their decreased LOC, they're sleepy. They could also have tachycardia. They're going to be breathing fast. They might be dizzy, flushed. They could have that pink coloring to the skin. If they're hypoxic and hypoxemia, you usually see that heart rate increase, the respiratory increase, blood pressure increase in an effort to increase that oxygenation and perfusion. But as that hypoxemia becomes worse, there's going to be less perfusion. So then you're going to see in later stages, that's when they become restless. They become confused and they're anxious. So eventually, if we don't treat it, they're going to be cyanotic. So make sure you're looking at the nail beds, the skin even. And that LOC is going to just eventually go into nothing. They're going to be in a coma. So it is important to remember that the patients that will present with not only the clinical manifestation of respiratory failure, but they're going to have also whatever is causing the problem. So it depends on if it's from a VQ mismatch, is it a trauma? Like you have to treat the trauma to fix the acute respiratory failure. So you're going to do ABGs, obviously, right? You're going to be checking their oxygen saturations, their H&H. You're going to get a chest X-ray, sputum cultures. ABGs are an excellent tool. We have to use these because we have to see the adequacy of both oxygenation and ventilation in the lungs. And you're going to see that with the ABGs. So hypoxemic respiratory failure has an initial period of respiratory alkalosis due to that hyperventilation, and they're hypoxic. But once those initial blood gases have been analyzed and we initiate treatment, we could still continue to monitor their oxygen level through pulse ox. But we really want that SpO2 to be greater than 94. So if we see that SpO2, that's the one we put on our finger, it's not the actual blood. If that's like greater than 94, which is, what we want, that could show that arterially that PaO2 would be about 80. That's great. That's what we would want. So, and again, remember our early stages of respiratory failure can progress. I remember in funds we taught rat bed. I don't know if you guys remember that term, but our early stages are dyspnea, restlessness, anxiety, fatigue, tachycardia. But as this progresses, they now are confused, they're lethargic, and that's because that CO2 is building up. So now their skin might get pink because of the CO2. And if we don't notice it, now they're cyanotic and they're in a coma. So remember your risk factors. Pulmonary embolisms, right? We can think back to that chart. So you can look at the risk factors for acute respiratory failure on page 553. Again, we're just putting this on the slide that go over the different types of respiratory failure from the different causes. So again, I could have that impaired ventilation from opioids because I'm not breathing adequately, or a trauma, versus something like that ventilation perfusion mismatch, more something like COPD or restrictive lung diseases like pulmonary fibrosis. And again, this is just recapping what you're going to see initially. Hypoxic respiratory failure has that initial period of respiratory alkalosis because we're hyperventilating and we're demonstrating hypoxemia. But your hypercarbic respiratory failure results your pH is less than 7.35 and your CO2 is greater than 45. So what do you think that you want to do to treat this? Well, this is not a disease, right? This is a problem from something else that's causing the problem. So it's not a disease, it's a condition. So that's the same when we're talking about respiratory in the critical care units. This is normally a problem that's progressed from something else. So we need to treat the respiratory failure that's going on, but we have to treat whatever is causing it. So if the cause is pulmonary edema, then we need to treat the pulmonary edema, or else that oxygenation problem is never going to be fixed. So that is the main point with this. So, I mean, the treatment of respiratory failure, it's going to begin with oxygen. We need to get them oxygenated. In many cases, minimal supplemental oxygen may help the patient's hypoxic status, but like in some cases, maybe we can get away with a nasal cannula or a Venturi mask. But if the patient is in respiratory failure, this is not the case. Like the patient in acute respiratory failure usually is not going to respond to traditional methods of oxygen. That's how we kind of know. So they need to be at least placed on a non-rebreather mask with 100% FiO2. So that full mask, we want to get them the maximum amount of oxygen that we can. So remember, you have to turn that all the way up. So, and that with those non-rebreathers, the bag has to be inflated in order for it to work. There are other high flow oxygen devices that you can use. There's high flow nasal cannulas. And that is like those oxygen devices can give up to 60 liters a minute of oxygen. So do you see the difference? Like with my standard nasal cannula, I can only give 8 liters a minute. These people need up to 60. So that is the difference between someone that's just having some difficulty breathing versus something like this, the acute respiratory failure. So if it's really severe, so say they're in a severe state, that VQ mismatch is really shunning all that blood and they're not getting oxygen, like we tried a non-rebreather, it's not working, then maybe I have to move on to something else like non-invasive positive pressure ventilations, which is my BiPAP or my CPAP. So the BiPAP, the main difference with that is it's bi-level. So this gives positive airway pressure versus CPAP, which is not 2 levels. It's just one continuous airway pressure. So that can be given to increase oxygenation really quickly. It's not as invasive as actually intubating the patient and putting them on a mechanical ventilator. So in BiPAP, they're getting those 2 different pressures. They have a high pressure when they're inhaling, and that opens up the alveoli. And then you're getting a lower pressure during exhalation, which keeps those from collapsing. So that is why BiPAP is helpful. In CPAP, it's just one pressure through the respiratory cycle, which just keeps the alveoli open through inspiration and expiration. Let's say we tried that and it didn't work, then they might end up having to be intubated, or maybe they need a tracheostomy placed and they're going to be placed on a mechanical ventilator. But the main thing is that we want to keep that positive pressure. So there's a term called PEEP. So positive pressure is maintained throughout this cycle, and how that's done is through PEEP, which is a positive end expiratory pressure. So this pressure is measured at the end of expiration, and it's maintained throughout the cycle. Like, this keeps those alveoli open. We don't want those alveoli to collapse. We want to get them oxygenated. So what do you think you need to do as the nurse? Well, airway. That's going to be first always. So you're assessing the airway for patency. How's their work of breathing doing? Do they have excess secretions? Do I need to be suctioning them? What are their vital signs? I'm going to be drawing my ABGs. Again, their hypoventilation of type 2 failure. That's going to result in that CO2 retention, acidosis, and ultimately that PaO2 is going to end up getting reduced. The VQ mismatch or diffusion defects of type 1 failure, those are going to result in that low PaO2. So if their hypoxemia is going on, their cardiac monitoring needs to be done, because that could increase the demand of the heart to be trying to pump blood to those tissues. So it could lead to dysrhythmias. You want to check their neurostatus, because think back to signs and symptoms of hypoxemia. As it progresses, they get worse. So we want to check for anxiety. A patient experiencing respiratory compromise, they're going to probably feel anxious or have that feeling of impending doom. We want to monitor for that. As that progresses, their LOC is going to decrease. Agitation is caused by hypoxemia, so you want to monitor for that. And the somnolence, that decreased LOC again, is really caused by hypercapnia. So you want to listen to their breath sounds, because if the respiratory failure is due in part to like pulmonary edema, we're going to hear crackles. If it's rhonchi, maybe it's pneumonia or COPD. If it's diminished breath sounds, maybe there was a trauma, they have a pneumothorax or some sort of obstruction going on. And definitely make sure that you are monitoring their skin color for things like cyanosis. You could see that in the nail beds, in the mouth, in the initial stages. And as it gets worse, that could develop into central cyanosis, which is in the body. So it could turn blue. So make sure that you are giving oxygen. It's necessary. We have to treat this with oxygen, or else we're not going to fix it. So supplemental oxygen is 100% necessary, and you want to make sure you're giving them humidity because of the amount of oxygen that we're giving them. You might end up doing some bronchodilating medications to open up those airways. We might be giving them steroids due to the inflammation that's going on, to reduce that, so that we can make sure we're giving them an easier way to breathe. We're probably going to maybe even do diuretics if they're having congestion in the lungs. We're going to elevate the head of the bed right away, sit the patient up. Always remember, positioning is important too. We still would position the patient with a good lung down. So if that underlying disease is one-sided, positioning them with a good lung down improves that gas exchange, because it optimizes that VQ ratio that we want. Gravity always ensures that the healthy lung maintains adequate blood flow. So that is why we put the good lung down. They might have chest physical therapy. They might be suctioned. They're probably going to have some nutritional support, depending. We definitely want to do oral care, skin care, making sure their nutritional needs are met as well. Because these patients, again, are very sick. So they're going to be in the ICU. And hopefully, once again, we treat the initial cause of whatever caused this problem, then they're going to recover, and they shouldn't have, hopefully, any long-lasting effects, depending on how long they were hypoxic. So please write down any questions on acute respiratory failure. We do have some videos also linked in the PowerPoints, and I do think it's good to watch the videos. on the comparison of the two after you're done with this. It's just good to like hear this more and more and more. Because now we're getting into acute respiratory distress syndrome, which is not a good thing at all. Okay, you can see on this slide the mortality rate is as high as 58%. That is very, very high. So COVID-19 doubled the amount of ARDS cases in the United States. So it's become much more of a problem that ICU nurses have had to deal with. So research has shown that the prevalence of ARDS has increased. It's between 15 to 18% of why all patients are actually mechanically ventilated. So the mortality rate still is very high. And it's usually not due to respiratory failure, but it's due to whatever caused the problem to begin with, because there's multiple issues going on, this multiple organ dysfunction, because there's such a massive inflammatory response that could have been brought on by the hypoxia or an infection of some sort, and the body just can't recuperate. So the most common cause of ARDS is infection. It's sepsis. So sometimes other reasons are things like pneumonia, aspiration, cigarettes. If they had a cardiopulmonary bypass, that could be a problem. Pulmonary embolism, drug overdoses, those could all be causes. But the pathophysiology and the clinical manifestation of this is a little bit different. So typically speaking, ARDS is defined by an acute onset of less than 7 days. This is something that happens very quick. And there is hypoxemia. There is also bilateral infiltrates that rule on an x-ray, and these rule out, we've ruled out cardiac pulmonary edema as the cause. So what happens is we're actually looking at diagnostics to diagnose them, obviously with ARDS, but because we had to rule out other things first. So there's different phases of ARDS. This progresses, and that this is kind of what this picture is showing you. There's 3 phases. There's an exudative, proliferative, and there's a fibrotic. So these progress as the stage of ARDS continues. So the exudative phase occurs within 24 to 48 hours after injury. So this is due to an inflammatory marker, whatever is causing the problem. So there's a disruption going on. So what happens is all of these inflammatory mediators are just crazy. So this disturbance allows this fluid to now go from the capillaries into the lungs, into the alveoli. So now these proteins and this disruption that's going on in the body, it's able to move from the vascular space into the lungs. So that's not good. Now we're losing that protein in the vascular tissues and those vascular spaces, and that makes the fluid shift even worse. Excuse me. So now we're going to see a really severe VQ mismatch going on. So we are not getting ventilated at all. But you're getting blood perfused. So that is why you're seeing that hypoxemia. Like your blood is shunted past the fluid-filled alveoli and it's not getting oxygenated. That is the problem in ARDS. So there's edema going on. There's edema, there's fluid in the alveoli and the interstitial edema as well. So we're damaging these cells. We're damaging the alveolar cells that end up producing the surfactant. So we need surfactant in our lungs for movement. Okay, so surfactant is responsible, that keeps that alveolar tension. So without that, our lungs can collapse. So alveoli surface tension keeps the alveoli from fully collapsing at the end of expiration. So if that tension's lost, then the alveoli collapse. So that's that atelectasis. That is what you will end up seeing in ARDS. So in the initial stages, you're going to see the patient in a stage of hyperventilation and tachycardia. because they're trying to compensate for that level of hypoxemia. So the ABG is going to reveal respiratory alkalosis due to the hyperventilation. So as this continues, they're going to enter into the proliferative phase. This is when the neutrophils and other inflammatory mediators cross over and they further damage the alveolar and the capillary epithelium. So this is not good. Now we're seeing a worsening in our VQ mismatch. Now they could have pulmonary hypertension that is going to happen, which could ultimately result in right-sided heart failure because that pressure is so high. So now this widespread change occurs throughout the entire diseased lung, and now they're going to get stiff, they're going to be non-compliant. So now our increased work of breathing is going to be even worse. So at that point, they're going to be really hypercarbic, and you're going to see worsening hypoxemia. What's really prevalent in ARDS is that you're giving them oxygen, but their oxygen level is not increasing. So it's increasing, we're giving them more oxygen, and it is not alleviating the drop in your PaO2. So that is because of all that fluid that is present there. So this is refractory hypoxemia, meaning that in spite of giving them increased oxygen delivery, it does not improve and it will eventually worsen. So lung compliance is going to keep getting worse, and that is going to make the patient continue to work harder to breathe. So if the patient's on a ventilator, it's causing more pressure to the ventilator, which we'll talk about more. The last stage is the fibrotic phase, and this is where there's diffuse fibrosis and scarring. So now we have really terrible gas exchange and compliance. So this is where right-sided heart failure is probably even worse. So you're going to see a reduction in blood flow. You're going to see that reduction in blood pressure and the cardiac output. So the VQ mismatch is so severe that we're just continuing to shunt blood, and it's just resulting in that refractory hypoxemia. So the overall result is severe tissue hypoxia and lactic acidosis. So this is why this is a very dangerous thing. So they do stage the level of ARDS. You're not responsible for knowing the stages. The provider is going to do that. But how you can see is that the mortality rate really increases depending on the level of ARDS. So they look at different settings to determine that, like how much compliance in the lungs did they lose. So if this patient is on a ventilator and they require like more of that PEEP, that pressure to keep the alveoli from collapsing, the more PEEP that they need, the worse the ARDS is, because that compliance is just so bad. So if we get into severe ARDS, that's when that level of mortality goes up. And these patients are definitely in the ICU. These are definitely needing to be monitored on like a 1-to-1 or a 1-to-2 basis. So again, you can have a direct injury or an indirect injury that could be a cause of ARDS. So if it's direct, think more like aspiration, chest trauma, pulmonary embolism, inhalation injury like smoke, pneumonia, infections, okay? If it's indirect, sepsis, shock because of those inflammatory markers, burns, because they're just at such a high risk for trauma with those burns. They have so much things going on everywhere. So if they have a drug or alcohol overdose, that also would be a risk factor for indirect ARDS to occur. Here again are the symptoms that you're going to see. You're going to see these dense, the snow screen effect is what we call it on the chest x-ray. So in the early phases, we really do these serial, like repeat chest x-rays to identify the bilateral infiltrates that are the hallmark sign of this disease process. So we always get a chest x-ray to be able to see those infiltrates. That is one of the keys. This is, again, it could be also described as a snow screen effect or a whiteout effect. So you can see how that looks on a chest x-ray. So we could monitor the disease progression through these serial chest x-rays. This is really, again, it helps identify and it guides the treatment. So we definitely want to get those done. But these patients are so sick that you're going to be doing every type of blood work on them as well. So you're going to be doing ABGs, your complete blood counts, probably sputum tests. And again, your ABGs are initially going to show hypoxemia and hypocapnia because that alveolar compromise. You're going to do a CBC because we want to evaluate if there's an infection going on. So if they have a really high white blood cell count, that could show an infectious process. And do all the cultures, sputum, blood, urine, because we want to identify the source of the problem. Coag studies, liver, kidney, because we want to see, is there problems going on in other places as well? So treatment. Treatment is twofold with something like ARDS because, again, we really have to identify what's causing the problem and we have to go from there. So really, your primary treatment for ARDS is going to be mechanical ventilation. So this is the primary treatment if they're having refractory hypoxemia because, again, it's initiated because that lung compliance continues to decrease, the work of breathing increases, and oxygenation continues to be refractory regardless of things like your BiPAP, CPAP oxygen therapies. So you're definitely going to be putting them on a ventilator. And the most common is anything like a high PEEP because we want to keep that alveoli open. So they're probably going to have a higher level of PEEP on the ventilator. And when we think back to tidal volumes, you kind of learn about those in other courses. Because of that, like we use your tidal volume, that's the volume of air that's moved with one breath, one inhalation and one exhalation. So, right, that's my tidal volume. If my lung is not really compliant, we actually want those tidal volumes to be kind of lower. So we use lower tidal volumes on a mechanical ventilator for these patients. Just because we don't want to cause an injury to the lungs. They're just very susceptible. So if I did too high of a tidal volume, I'm causing too much trauma to the lung. I could cause some sort of lung damage, which is actually known as barotrauma, and we will go over that. So we definitely are going to use oxygen, ventilator. We're going to position the patients. If you think about back to acute respiratory failure, how we mentioned keeping that good lung down, it's the same thing with ARDS. We actually really do positioning as one of the adjunctive therapies in ARDS, and that typically means we place them in a prone position because while they're ventilated, we can still put them on their abdomen because both lungs are bad. But it does show to be helpful. So it just has been shown that it improves that oxygenation and it helps reduce that VQ mismatch because of the gravity. It works better in severe ARDS if we tried other type of strategies and they did not work. But you do have to really plan out things like that for proning. And you have to remember your contraindications for that, like unstable rib fractures. We can't prone them for that. We can't prone them if they have certain intracranial pressure issues, if they need a frequent airway access, because it could be difficult to flip them over. So there's a chart 27.2 that goes over the use of proning in the patients with ARDS, and I think that that chart is very helpful. So again, mechanical ventilation is the primary treatment for ARDS. We're going to keep a high PEEP and low tidal volumes, and we are probably going to prone them if everything else has been unsuccessful. They're going to be on multiple medications. If it's due to an infection, we need to give antibiotics, right? So we always start broad. Once we get the cultures back, we know what we're dealing with. We could then get narrow. You're going to do corticosteroids to decrease that inflammatory response. But This use is controversial, so it may or may not be done. There is no evidence that the use of steroids actually improves mortality and morbidity in this, but the anti-inflammatory properties are thought to help. So you might see some providers do it and some providers not do it. The neuromuscular blocking agents or paralytics are sometimes used when they're mechanically ventilated, just because it reduces that risk of barotrauma, because they control the patient ventilator, the breathing. The patient's not fighting the ventilator. So the patient can't take a breath out of sync with the ventilator. And it reduces like their oxygen demands because they're not moving their muscles as much. If we are using neuromuscular blocking agents, they also must receive pain and sedative meds, because you have to make sure they're comfortable. Just because they're paralyzed, you're not treating their pain. So you have to be treating their pain as well. And really, paralytic agents are usually only used for patients in severe ARDS, and they need to be reevaluated at least daily for every single patient. Going back, your fluid management is important because we need adequate hydration to maintain circulatory volume and, help keep the tissues hydrated. So ARDS and sepsis is, again, usually caused by that massive vasodilation and leaking. So there is intravascular fluid that could enter the lung. So a lot of those ARDS cases do require some use of diuretic, depending. It depends, because we want to shift that fluid out of the lungs. So it depends, but so it's like a special balance. If we give too much fluid, ARDS can worsen. So this is, again, why it's someone that is really one-on-one, because if an insufficient amount of fluid is administered, preload and blood pressure may decrease. So then we're not getting perfused and we're still not getting that oxygen where we need it to be. So do you see the conundrum with the treatment for this? So there are a lot of charts in here that go over all of the type of medications. They also do give you examples. So remember your sedatives like dexmedetomidine, which is Precedex. That would be a sedative that's given IV. You could do a neuromuscular blocking agent like succinylcholine. That would be IV. You have your anesthetics, which is just general. It's not a paralytic, like propofol. You have your benzodiazepines like midazolam or lorazepam, and your opioids like fentanyl. And just remember, like, your medication management for these patients is going to be intravenous, right? Or they're going to have an NG tube for their nutrition. They're not going to be able to eat while they're intubated and getting mechanically ventilated. So the fluid and the medications are all going to typically be done through their IV, because you cannot also just neglect that nutrition, because they're critically ill and we need to be fueling their bodies for healing. So enteral nutrition is always preferred, unless it's contraindicated, like if they have some sort of GI issue. Tube feedings are associated with aspiration, so we want to be careful with that. And parenteral nutrition, that could be associated with increased infection because of the catheter. So it will depend on your client. But this is just going to kind of recap your nursing assessment here, right? So again, the patient's increased work of breathing, that accessory muscle use, that really could be the first indication that they are going into ARDS. So they could have crackles, they could be developing pulmonary edema, and then later, due to those fibrotic lung changes and the collapsed lung, maybe they don't have any breath sounds at all. So I was like, what is going on with this patient? So I tried nasal cannula, I turned it all the way up, and their SpO2 just continues to fall down despite me increasing their oxygen. Then I was like, wow, this is weird. I get them on a Venturi mask. That's still not working. We try a BiPAP, still not working. That's how you can really identify that this patient is in ARDS. You do a chest x-ray. You see those whiteout effects, that snow effect, and it's bilateral and it's not due to something else. That would be a sign that they are in ARDS. So this patient needs to be hemodynamically monitored closely. They're continuously monitored. So their vital signs are continuously done. The pulse increases. Again, initially, they're probably tachycardic at first, just because of that compensatory method. The SpO2, it's going to be low because of that VQ mismatch. Thinking to our hemodynamic monitors, our central venous pressure, that CVP, or our pulmonary artery, that PA pressure. Those could be variable, but they are going to be monitored. They could be decreased because of the decreased venous return that's going on. They also could be increased due to increased vasoconstriction in the lungs. So those could vary. Your neuro assessments, you want to be checking their level of consciousness and their pupils, just because they are at risk for neurological compromise because of that hypoxemia, and their CO2 could increase. So we definitely going to be doing frequent neuro checks, especially if they're sedated. So you're going to be using a tool like your Richmond Agitation Sedation Scale to monitor their level of sedation. You're going to be assessing their lungs. You're going to be assessing their airway secretions. Again, monitoring their urine output, keeping the lab tests or ABGs. Our lactate is probably going to be high because they're in anaerobic metabolism. Abnormal kidney or liver is going to indicate the progression of ARDS, which could lead into multi-organ dysfunction syndrome. That is what they most likely are going to die from. So you are assessing their urine output, their skin color, right, continuously. And the chest x-rays are going to be done daily because we're monitoring the progression of ARDS. So you're going to be suctioning the airway if we need to, especially if they have a breathing tube in. You're going to give their meds, do the positioning. Again, remember, they might be prone. Since if we do have someone like this sedated, then you need to be doing range of motion for them. You're going to make sure that we're not contributing to further infection. So doing our hand washing, monitoring all those lines. They're going to have a Foley catheter in. So, and you have to make sure you're doing your diligent mouth care, because these are some of the complications, again, that can happen just from them being so sick. Like our kidney failure. And again, like I just said, that renal failure could happen, but kidney failure could be prevalent just because we're giving them so many medications and to try and treat it. And eventually that could become nephrotoxic. So you do want to monitor for things like that. It is a very frequent complication of ARDS, renal failure. And it could, again, indicate the progression to MODS. So MODS always is going to result from that prolonged refractory hypoxemia and that inflammation. So that's really discussed in chapter 14. The barotrauma, again, because our lungs are stiff, and so I'm trying to, maintain my ventilator to the appropriate setting. So I'm trying to be careful with that amount of volume I'm giving them. So if something like barotrauma were to happen, that's when the alveoli rupture, because I did too much and because that intrathoracic pressure is too high. So alveolar or lung might rupture, which could result in air in that mediastinal space or air in the pleural space, which would be your pneumothorax. So that would just make things even worse. That could worsen the hypoxemia. So you're really trying to prevent barotrauma. So the peak pressures are always monitored on the vent. Your suctioning in ARDS should be done only as needed, because that's going to increase that intrathoracic pressure. You're going to make sure you have low tidal volumes on the ventilator and that you're monitoring your ABGs to make sure everything looks good. And you're going to just make sure that the sedation and the paralysis should be maintained to promote the patient from fighting the ventilator. Any sort of hospital-acquired infection, if they're ventilated, we could cause ventilator-associated pneumonia as well, because they have this artificial airway in place. So all of our normal ways to kind of protect them from pneumonia are compromised. So the primary risk for pneumonia, it's going to be when that epiglottis can't close. So pneumonia is difficult to detect when a patient is, already ventilated because of ARDS. So it really is difficult. So now, because they might already have a fever, so how could we tell? So again, you're just kind of watching the signs and symptoms. So if they all of a sudden develop a fever or their white count goes up, they were comfortable, but now the respiratory rate is increased and now their drainage is purulent. So those would be signs that now they have pneumonia. So you would want to do a sputum culture because that's going to show infection. And the earlier it's diagnosed, the better it can be treated. So you want to prevent this from happening, essentially. So you want to do regular mouth care. That's one of the best ways to prevent this from happening. So suction routinely is needed. The ventilator circuit should be changed per the policy of the hospital that you're working at. And you want to make sure that the water does not build up in the circuit and that you're using sterile water for humidification so that it's clean that they're breathing in. So those are the main points with ARDS, and I know that that is a lot. So again, we have the video linked, a very short like nurse video that goes over ARF and ARDS. I think that those videos are really helpful and a recap, and we will recap some of this in class as well. And in class, we're really going to go over the ventilator stuff more. We'll go over like your weaning criteria for the ventilator, and again, watch the video before you come to class that really goes over the ventilators more. And we also have lab, which will go over some of this as well. So please write down any questions that you have. We're almost done with this. We're getting into some of the chest traumas that can happen and your treatment. And some of this is actually review at this point. So again, I mean, your chest traumas can happen from anything, right? So motor vehicle accident, again, is really the most prevalent cause of any sort of accident that's happening. So you're going to be, there are different types. You could either have a blunt force or penetrating. So they kind of make sense with how they sound, right? The blunt force is when something hit me, and penetrating would be something actually going through my skin like a knife. So, and you could even further categorize these, but don't go crazy on this. The main thing that we want to kind of go over are what are the things that can happen as a result of a trauma. So these are the things that you're going to be really looking for. So again, like these are the injuries that could happen from the chest trauma. So, and you have learned a little bit of this. If we have a flailed chest, okay, and we'll show you a video of this. Even if you Google this or watch something on YouTube, it looks really crazy. So a flailed chest is when 3 or more adjacent ribs have been fractured in 2 or more places. And that's usually due to like a blunt or a crushed chest trauma. So it causes this paradoxical chest wall movement, and that's how you can identify that it's flailed chest. So I'll show you a video that shows that paradoxical chest wall movement. That is what flail chest is. So with every inhalation, every breath they take in, that damaged area moves inward. And when they breathe out on exhalation, that section of the chest wall moves outward. So it's kind of different. It looks weird. So yeah, it looks crazy, but it's due to the ribs being broken. So the severity of the injury and the treatment are really going to depend on the extent of the injury. So, and they also have a chart on this in the book, which kind of shows that. So we'll take a look at that. I mean, your pneumothorax, that could also happen from the chest trauma. And it's typically though from a penetrating chest trauma that could result in an open pneumothorax, but blunt would be a closed or open pneumothorax, but they both basically cause a disruption in the lungs. So it's basically just a collection of air in the pleural space. So a normal lung is going to inflate when we take an inhalation because of that negative pressure that's there. But when you have a pneumothorax, there's a reduction in that pressure because the air's there. So it makes your ability to breathe in a lot more difficult. So the lung is actually not able to fully expand. So now we're going to show some hypoxemia because you're not able to get good gas exchange at that alveolar level. On the other hand, a hemothorax is blood in the pleural space. So that could be from a knife right? We have bleeding. There's a bleeding of a pulmonary vessel. Something's going on from that penetrating type trauma. So that could result in different problems for the patient. Okay, because as with a pneumothorax, if we have blood that's filling, now that negative pressure is lost. So now the lungs really are not able to expand and they're losing blood. So that could result in that hemodynamic compromise that the patient could have. So they could become hemodynamically unstable. So here's that picture I was talking about the flail chest. I just wanted to show you that. Here are your risk factors for any of these, again, which we went over. So how are we going to diagnose this and what are we going to see? Well, you're going to do multiple different tests like a chest x-ray, an ultrasound, and a chest CT most likely. A chest x-ray is going to let us see the integrity of the lungs. It could show the fractures. It can show the ability of the lungs to expand. It'll show a pneumo or a hemothorax. And ultrasound could be used to rule out something like the cardiac tamponade, which is when you have that blood in the pericardium, which compresses the heart, which could be a life-threatening injury if it's not treated quick. And you're going to do a chest CT because they were just in a trauma. So that's always a basic workup for any sort of trauma. And sometimes we might not see things with a chest x-ray. So we can evaluate a lot with that. You're also probably going to get some blood work done just because this is more of a trauma type patient. So what are you going to do for treatment? Well, ABCs, right? You're going to have to guide it based off of that. You're going to evaluate the airway. You're going to see their ability to breathe, and you're going to evaluate their circulation. Do they need IVs to maintain that hemodynamic stability? Do they need oxygen? Are they able to protect their own airway? Are they bleeding out? Do we need to stop the bleeding? So your nursing care is really going to depend on the signs and symptoms that the patient is showing. And the main thing that we're going to do here, I'll come back to that, is treat them depending on their symptoms. So if they're in a lot of pain, I want to treat their pain. So most likely IV pain medications, right? Just to kind of get that breathing to be a little bit easier for them. Because if they're in extreme pain, they're not going to be able to breathe deep enough. So we don't want them to go into atelectasis from that. So initially, we're probably going to do IV narcotics like morphine. They may also have a block done, like a regional block or an epidural, to reduce the pain, to block that from happening, because that can also help the patient to breathe a lot more better. And the benzodiazepines to help decrease their anxiety. Because what can happen if we don't treat this patient is, again, they're going to become hemodynamically unstable and they could go into respiratory failure. Another thing that can happen is attention pneumothorax. So this can happen if air or blood collects in the pleural space and is not removed. So if this is left untreated, that positive pressure increases and that lung is going to collapse. So as that positive pressure does increase, it actually can cause a mediastinal shift toward the unaffected side. So that results in tracheal deviation towards the unaffected side, and that's the hallmark sign of attention pneumothorax. It is an emergency. It's a life-threatening emergency because of the left ventricle of the heart is failing and you're not getting cardiac output. So if it's an emergency, they're probably even going to do, if it's like attention pneumo, they could do a needle decompression just to immediately remove that air from the pleural space. So they actually take a large bore needle and they insert it into the ribs there, just to rapidly evacuate the air or blood. And then we would immediately put in a chest tube. The other thing that could really happen is a cardiac tamponade, like we kind of talked about, and that again is caused by excessive air, fluid, blood that collects in that pericardial sac, And when this occurs, the heart cannot adequately fill. So that could manifest as different things. It can manifest as hypotension. They have a very narrow pulse pressure. They have muffled heart sounds, so you have to always be assessing their heart sounds. And they have distended neck veins. And that collectively is what's known as Beck's triad. So cardiac tamponade, due to that fluid that's accumulating there, is treated with a pericardiocentesis, basically kind of similar to the tension pneumo, where they take a needle and they drain the fluid. So they also might leave a catheter there to allow for continued drainage to happen. So cardiac tamponade could be due to tension pneumothorax because of all that tension that's there. So it kind of depends. I mean, you're always maintaining astute assessment and reassessment in order to intervene immediately if these happen. If an at-risk patient goes into cardiac arrest, you're going to do basic life support, obviously, right away. Here's some more pictures. Now, when it comes to the chest tubes, you kind of have done, you did do some education on chest tube management prior, but we're actually going to do like dressing change and things on the chest tube in lab. That is your one checkoff that you actually have this semester. But you need to know like how to maintain your chest tube. And we're always thinking, what do I need to do in regard to this? Because if they have a pneumothorax or a hemothorax, they're going to put a chest tube there so that that stuff can get drained out and that they can breathe better. So there's different, I put a couple videos here where they explain the chest tubes. They show you the setup because it makes more sense when you see it. And again, you're not really going to see this until we have lab, which is after your exam. So you're not the one putting in the chest tube, but you are the one that's monitoring it. So again, like the chest tube placement is going to be indicated if there's a pneumo or a hemothorax because of a chest trauma. So if there's pneumo because of the air, the chest tube is going to be placed kind of high, like in the second intercostal space. And if it's a hemothorax, the chest tube is typically placed lower, like at the fifth or the sixth rib. And that, again, is just going to allow that fluid to drain. So it is connected to a chest drainage system, which is what you are monitoring as the nurse. And it flows into a collection chamber. There's a water seal and there's a suction. So that collection chamber is where that fluid or the air accumulates. And there's the water seal that acts like a one-way valve. So it allows for the removal of it, but it doesn't let it go back into the lungs. That's why it's one way. Initially, suction is applied because we want to re-expand the lung. So as the lung kind of heals, then we can turn the suction off. But what you're really going to be monitoring for is how the chest tube is doing. So you're going to be assessing the amount and the color of the drainage. So the drainage should be measured, marked on the chest tube collection device and documented. If there's red free-flowing drainage in any sort of excess of over 70 mLs an hour, that could indicate hemorrhage, which you'd have to notify the provider. Cloudiness could indicate infection. You also always want to be mindful of any sort of trends with the chest tube drainage. If there's like a sudden increase or a sudden decrease, you want to assess that. You want to assess the water seal chamber. Initially, there should be some bubbling on expiration because that indicates that you're removing that air. But as this continues later on, after the air has escaped, the water level is going to fluctuate. If there is a pleural wall disruption, like that ends up getting healed, there might not be any fluctuation in that water chamber at all. So that's when you would really evaluate the patient, like, could we get this chest tube removed? If there's continuous bubbling, we shouldn't have that. That could show that there's an air leak in the system. So we would want that evaluated right away. And subcutaneous emphysema is if we can palpate crackling under the skin and it's not painful, but it is indicated of air and subcutaneous, and it is not good. We don't want that. So that could indicate potential chest trauma, and subcutaneous emphysema may also be a clinical indication that the chest tube is not in the right place because the air is going around it. So subcutaneous emphysema of the head and neck, think about that extra air here could be life-threatening. So that's not normal, and you have to notify the provider if you can palpate any sort of crackling. So never clamp the chest tube ever, because that could cause a lot of problems. We never clamp it. We always maintain a closed system here because it's sterile. We don't want to introduce infection. You always keep it also below, like a Foley, below the level of the chest. You want to keep the tubing free of kinks. We don't want to cause a blockage. If they're sitting on the tubing, then it's not going to drain out. So if you were to clamp it, then you could worsen the pneumo. The whole point of it is to keep it open so we're getting the air or the bleeding out. When you do remove it, you immediately apply a sterile occlusive petroleum jelly dressing over it, because that occlusive dressing prevents air from re-entering into that space. So administer any sort of pain meds to help that. We want to keep their pain under control. Now, let's say that it was a worst case scenario for the patient that came in with a chest trauma and everything we're doing didn't work, or it's so severe, maybe they're going to do surgery if it's really unstable. If it's like a really severe case of flail chest, they definitely might go to the operation room to stabilize those. So basically the thoracotomy is just that surgical excision in the chest wall. So maybe an organ was damaged or something and they need further care. So we kind of talked about this. Any sort of trauma, you're assessing for other problems. So you're going to be managing the chest tube, you're assessing the respiratory effort, you're looking at the chest, you're actually visualizing it. Again, you're looking for any sort of tracheal deviation, that would be a medical emergency. You're listening for the breath sounds. They could have absent, right, breath sounds. That could show a pneumo or a hemothorax. If there is fluid or blood in the lung, that could result in rhonchi or crackles. So this is why we really have to listen. So treat their pain. Again, ABGs. You're going to be applying oxygen. Always think worst case scenario. Maybe this patient's going to need to be intubated, but we're going to try and prevent that. Keep the head of the bed elevated. Never forget your basic fundamental things like encouraging the deep breathing and coughing every 1 to 2 hours, incentive spirometer, early ambulation. Those are all things that we'd want to do. Educate the patient on what you're doing. Educate them on the importance of getting up, getting out of bed, right? Walking, deep coughing and deep breathing. So again, please review any questions that you have on any of that. We're going to go over again some of this in class too, but you can leave comments in Cafe Corner anywhere that you need. I did want to also review Chapter 9. I know that you do ABGs in semester 7, but this concept is kind of confusing, and you are going to have to be able to look at a scenario, evaluate the ABGs, and say what you expect or how you might treat that. So I did end up adding some slides on this again. Remember that we will give you a lab value sheet, so you don't have to memorize all of these lab values, but you do have to know what's acidic and what's base, right? What's alkalotic. So our acids are our hydrogen ions. So we're going to be acidic if our pH is lower. So if it's less than 7.35, and our bases are known as our hydrogen ion acceptor. So it's a base, an alkaline, so that has fewer hydrogen ions, so that pH is going to be greater than 7.45. And your most common base is your bicarbonate. I wanted to go over this really quick. How does the nurse interpret an arterial pH of 7.47? Would that be A, B, C, or D? Well, it's greater than 7.45, so that would be alkalosis, right? It's not normal. There's not any homeostasis going on. So that would be alkalosis. Now, what about compensation? What are we talking about when we do mention compensation in general? Well, we are talking about a normal pH. So when you're evaluating any sort of ABG result, then if the pH is normal, it is compensated. So it really describes any sort of physiological response that there was an attempt, there was an imbalance at some point, and now we attempted to normalize the pH. So if the problem is from a respiratory problem, then the kidneys are going to work to correct that. If the problem is of renal origin, then the lungs are going to work to correct that. So compensation could be affected by different things. So again, if we're retaining CO2, our hydrogen ions would be high, our pH would be low, and your body response is that increased depth and rate of respirations. But if we're excreting CO2 and our hydrogen ions are low, our pH is going to be high and our rate of respirations is going to decrease. So you're going to see respiratory compensation. If the primary alteration is an acid base from a metabolic disorder, then the respiratory system is going to compensate by either retaining or removing CO2. So the lungs, they could take not too long to try and compensate. I mean, that could be as fast as 5 to 15 minutes. So if it's metabolic acidosis, then it's an increase in respiratory rate and depth. And if it's metabolic alkalosis, there's a decrease in respiratory rate and depth. And when it comes to renal compensation, then if the primary alteration is an acid base from the respiratory disorder, then again, the kidneys are going to try and compensate by either excreting or retaining hydrogen and bicarb. So that takes a little longer. That could take up to 24 hours to try and correct that because of how many different systems are going on to try and fix that. So again, so when we talk the types of compensation, so you have to be able to look at this and say, is it compensated or is it not? If it's uncompensated, then the pH is abnormal. Okay, that's always your first step at looking at is the pH. And either the PaCO2 or the HCO3 is also abnormal. There's no indication that the opposite system is trying to fix the problem. If it's partially compensated, again, the pH is abnormal, okay? And both the PaCO2 and the HCO3 are abnormal because one of them is trying to fix it. That's the main difference between uncompensated and partial. In uncompensated, everything is abnormal. In uncompensated, the pH is abnormal and one of the two is abnormal, not all three. But if it's partially compensated, then they all are abnormal. If it's fully compensated, the pH is normal. So when you're reading these, always look at the pH first. If the pH is normal, that's all you have to look at. It's compensated. I mean, typically speaking, that fully compensated, the pH is normal, and both the CO2 and the HCO3 are abnormal, but it was able to compensate. So because the pH is normal, that's what it's trying to do. I mean, we need that homeostatic pH environment for the body to function. That's why it's okay for the kidneys and the rest, but for those to be a little bit abnormal. So when there is, it does take a little bit of time sometimes to compensate. So what I really want you to be focusing on is being able to look at that, but then being able to know the causes and how that patient would look in with that reading. So always remember, and this, if you're looking at respiratory acidosis, like what could cause that? So if I have a pneumothorax, then I would anticipate the patient to possibly be in respiratory acidosis. This is going to be where your ABG result, you're acidic. So that pH is going to be less than 7.35 and your CO2 is going to be greater than 45. You're also going to have some level of metabolic compensation, so that HCO3 that is going to be greater than 26. So what are you going to see here? Dysrhythmias, respiratory distress, confusion, tachycardia. And how are you going to treat it? That's what I want to know. So if it's a respiratory problem, then you have to correct or improve the ventilation, because we want to lower that CO2. So maybe you're going to do bronchodilators or oxygen, antibiotics if it's an infection. Maybe they need a chest tube. So when you're studying this, really study the charts. Really look at, okay, what are the manifestations of respiratory acidosis? What are the causes and what's the treatment? So then if I went right into respiratory alkalosis, here you can see the causes and here you can see the symptoms. If I'm looking at the ABG, for respiratory alkalosis, it's alkalotic. So that pH is going to be greater than 7.45 and my CO2 is going to be less than 35. You're going to have metabolic compensation. So my HCO3 is less than 22. So how am I going to treat this? Well, you have to figure out what's causing this, right? Because in this, a lot of the causes are fear, pain. So I would want to treat that. Early pulmonary edema. There's the pulmonary embolism, again, that could cause respiratory alkalosis. So I would need to treat that. What you can do is further measures. You could counteract hyperventilation. So you could teach the patient to breathe into the paper bag, because now they're rebreathing the exhaled carbon dioxide. If they're intubated, you could adjust the ventilator settings, because we would want to decrease the tidal volume or the rate. So it's the same thing here, metabolic acidosis. I have too many acids, right? So you're going to see a decrease in serum bicarb because of 3 different things. There's different reasons for this too. So if you're evaluating your ABG for metabolic acidosis, your pH is still going to be low. Your HCO3 is going to be less than 22. And if my respiratory system is compensating, my CO2 is going to be less than 35. For this, you really have to identify what is causing it. You can see if there's diarrhea, I need to treat the diarrhea. So this really depends. You could give sodium bicarb to neutralize that acidity that's going on. If the pH is lower than 7.1, you need to maintain your fluid balance. Maybe give them insulin if they're, have diabetes, and we would want to drive that potassium back into the cells. So maybe give them antidiarrheals. So you guys can see what I'm getting at. Really just review this chapter. So if I got into some questions here, which parameter of the ABG result correlates to the assessment of the bases? What do you think here? Well, my HCO3, right? And my normal range is 22 to 26. So again, it is my, that renal component of the acid base regulation. What about this one? What acid-base imbalance does the nurse suspect on the basis of these results? Your pH is 7.31, CO2 is 52, and your HCO3 is 28. So my first step would be to look at my pH. Is it normal or is it not? It's not. So we know that it's not compensated, right? And it is acidic. It's low. So then I would be looking at the CO2, which is 52. That's high. My CO3 is 28, which is also high. So are all my values abnormal? Yes. So it is trying to compensate, right? Yes. So this would be partially compensated respiratory acidosis because it is partially compensated here. The patient's ABG result indicates worsening respiratory acidosis. He has rapid shallow breaths and decreased bilateral breath sounds. Which intervention should be the nurse's first priority? I'm going to let you look at this. Well, I don't know about you, but I would think airway. So I would want to intubate the patient. So you should be thinking D. Now I have 2 more questions on here. I want you to review these and write down your answers, and we will go over these in class. So please, we will give you ABGs to practice. There are videos. I have worksheets. We will re-review all of this, but this is a good start. So please, if you have any questions, please write them down. Otherwise, I will see you in class.